Welcome to today's MedTalk. I see we also have participants from outside Agilus. So just to update you, MedTalk is a platform wherein we conduct continued medical education programs. We hold symposia, we've held workshops, and we've also held slide seminars. And today we are doing a slide seminar on oncopathology. And we have here with us today our Agilus Histopathologists. So at Agilus, we have multiple histopathology centers. Leading them is the Center of Excellence at the Mumbai Reference Lab, where Dr. Kunal Sharma heads it. And then we have histopathology centers in our other reference labs, standalone labs, and in hospital labs, both Fortis and outside Fortis. We also have histopathology centers in our sister concerns like DDRC and the Dr. Avinash Phatke labs. So overall, you'll realize that within Agilus, we see a very wide spectrum of cases from across India, and also we get a good number of international cases. And the focus today being on oncopathology, we have our oncopathologists with us who will be presenting interesting cases in oncopathology. The moderator today is Dr. Kunal Sharma. Dr. Kunal Sharma, as you know, is Associate Director and Head of the Agilus Center of Excellence in Histopathology at the Mumbai Reference Lab. He also leads digital pathology and artificial intelligence for Agilus. So today we have actually brought together a little bit of digital pathology, and the slides have been uploaded on Path Presenter so that they were visible to everyone. You could form your differential diagnosis so that the session today would be more interesting for everyone. Dr. Kunal has been a keynote speaker, presenter, and faculty at numerous prestigious national and international conferences, including the Indian Cancer Conference, OncoCon, more recently, Dr. Advani's legendary oncology series for the second time, if I'm right, Kunal?
Yes, ma'am.
And also innovations in oncology, the Global Cancer Congress in Japan, CAP USA, and so on. He is on the editorial board of various journals, including the Indian Journal of Surgical Oncology. His twin interests of oncopathology and digital pathology have led him towards Path Presenter, where he is chief editor of the hematolymphoid neoplasm section. Dr. Kunal also stepped up during the COVID pandemic, where he was a team member of the COVID Rakshak initiative, and he was felicitated with the COVID-19 State Warrior Welfare Icon of the Year award, and also other numerous awards. So, but most importantly, he's also a very popular oncopathologist. He's a popular oncopathologist, both with the pathologists and also with the medical and surgical oncologists. And he has cases coming in from across continents now. He's leveraging his knowledge to facilitate prognostic treatment, molecular diagnostics, and companion diagnostic assays. So Kunal, please take over now and we'll begin the slide seminar.
Sure, ma'am. Thank you so much for a really, humbling introduction. I think our team of histopathologists here and, the way we work cohesively is the reason why we have some really, really interesting cases for everyone to see and, how we go about them. So without much ado, I would like to start with the first case. This is a case that will be presented by Dr. Arun Panda from FMRI and supported by Sunita ma'am. This is a case of a 16-year-old male patient who was previously a diagnosed case of NLPHL in 2015. And post radiotherapy in cervical nodes, he has now presented with generalized lymphadenopathy. And it's a very widespread disease, which also includes the skeletal system. What they got was an excision biopsy from the abdominal node. I also saw this case, and it was very, very interesting. And it had many, many different opinions from different centers. So, Dr. Arun, I will hand over the platform to you for presenting this really interesting case.
You need to unmute yourself, Arun.
Good afternoon, all. This is a 16-year-old child. Sir has already told the history, presented to OPD with a history of diagnosed case of NLPHL in an isolated cervical lymph node 7 years back, and it was treated by radiotherapy. So only radiotherapy is also a protocol of treatment in NLPHL when it's present with an isolated lymph node. Now, patient is relapsed, present with general lymphadenopathy with skeletal mets, and we got an excision biopsy of the, sorry, it's not cervical lymph node, it's from the abdominal lymph node. So there was two diagnoses before I got this case. It was diagnosed as NLPHL transforming into T-cell rich B-cell lymphoma in one outside lab and NLPHL in another lab. So as the HE slides are already given to all, and we can see the architecture of the lymph node is effaced, and you can see some vague nodularity and also in seeds. All these low power, we can see the lymph nodal architecture influenced by multiple nodules and also in seeds. So in the high power, we can see monolobated and bilobated large cells with a background of small lymphocyte, histiocytes, and high endothelial venules. We can see those binucleated cells and monolobated cells. So, and these cells have prominent nucleoli. So the DD here with me is again NLPHL and classical Hodgkin lymphoma. Here we can see these large monolobated and bilobated cells in a background of mature lymphocytes and histiocytes. So this is CD45. Here we can see these large cells are LCA negative, with the background cells LCA positive, and these large monolobated and bilobated cells are LCA negative. Interestingly, these all large cells are CD20 invariable positive, means so these are all the large cells are CD20 positive, and CD30 also positive in the large cells. This is PAX5. We can see the internal control of the small lymphocyte, which are dark bright, as compared to the large cells, which are very dim, very mild positive of these large cells. And MUM1 here it was variable positive. We can see I have already shown some cells are negative and some cells are positive MUM1. And this is OCT2. The large cells are OCT2 positive, strong OCT2 positive, and this is BOB1. The large cells are BOB1 negative. And the background cells are highlighted by mature CD3 positive T lymphocytes. And EBB was a negative EB LMP, and Sir has done EBRIS also, and it was also negative. So to summarize, we have a effaced nodular architecture of the lymph node, effaced architecture with multiple nodules and somewhere in the seeds. And these cells are LCA negative, CD30 positive, PAX5 dim positive, BOB1 negative, and MUM1 variable positive. So it was in favor of classical Hodgkin lymphoma, and in favor of NLPHL, the nodular architecture and invariable CD20 positive. So here, going to the literature, we can see CD20 positivity in classical Hodgkin lymphomas, but most of the cases are heterogeneous CD20 positive, but literature showing 5% of classical Hodgkin lymphomas can show invariable strong CD20 positive also. So looking at the different findings and the more of the features showing a class in favor of classical Hodgkin lymphoma. So here the thing is architecture or the morphology. The DD is always confusing. It can be NLPHL or can be classical Hodgkin lymphoma, but IHC profile shows actually in a classical Hodgkin lymphoma, the programming of the B lymphocytes most of the time it gets lost. So we won't see the CD B cell phenotypes in classical Hodgkin lymphoma, which is retained most of the times in the NLPHL. So here we can see the PAX5, DIM, BOB1 negative, MUM1 variable, and CD30 literature shows ki some 5 to 19% of cases of NLPHL can also show CD30 positivity, but showing and NLPHL, the large cells will be LCA positive, where here the cells are LCA negative. So having all these features, we diagnose this case. And the clinical feature, the boy is 16-year-old. If we see the literature, the maximum peak of the NLPHL comes between 30 to 50 years of age, and as compared as classical Hodgkin lymphoma will have bimodal distribution in the children and in the 40s to 50s. So the clinical features, again with the bone involvement and generalized lymphadenopathy, we final diagnosis made is CD20 positive classical Hodgkin lymphoma. Thank you.
Neeta ma'am, any comments from your side?
You know, this patient when came to us, it had been diagnosed with it came with different diagnoses from eminent pathologists of all over India. And then to our surprise, we found that I felt it is looking like a Hodgkin lymphoma on morphology, but then it came out to be very strongly CD20 positive. And at that time, we were not given this history that he has diffuse involvement, skeletal involvement. There is such an extensive disease in the bone. And so I kept telling that, this is looking like Hodgkin. Then I had actually sent this case for Eber to Kunal and to have his opinion. And because this had it would have resulted in so much of controversy, and the parents were also not ready to accept that he has a much bad disease than NLPHL. So I thought a second opinion is required for our own safety. And so we both gave a diagnosis, same diagnosis, that is CD20 positive CHL. And then the history of the extensive bone involvement and disease in stage 4 disease was given. And then we were much more sure that yes, this is more likely to be a CHL than an NLPHL. And so the message here is, especially when you have a follow-up disease, find out, always better to review the old slides on which the initial diagnosis was made, and also to find out the detail of the clinical presentation at the moment. So two things can happen. The disease may progress, because NLPHL can progress into a classical Hodgkin and into NHL. Both type of lymphomas can progress from NLPHL. So the previous block review, detailed history today at presentation, both are equally important before you give a diagnosis.
Thank you, ma'am. So to sum it up, I think it's an excellent case that tells you very subtle differences between NLPH and classical Hodgkin's lymphoma. Just for everyone, I really feel that if you have CD30 positivity, and if you have PAX5 weak positive, PAX5 in NLPHL will always be much more stronger than even your B lymphocytes. And 30 usually is negative in a case of classical, in a case of NLPHL. 30 usually stains the surrounding immunoblasts in NLPHL. Mostly NLPHLs are negative for 30. And if you have a very disseminated disease clinically, which we of course got to know later, but if it's below the diaphragm involving multiple systems, you should always be very guarded in giving a diagnosis of NLPHL. So with that, we move on to our next case. Our second case will be presented by
Kunal, there are a few questions on the chat. Would Dr.
Sure,
Sunita
ma'am. We'll address
answer
them. Sure. I'll just see. Okay. So question number, okay, one common question is, what about CD15? Dr. Arun, would you like to answer?
हमने
Yes.
सुना नहीं
Actually,
Ma'am, what about CD15 they have asked?
CD15 actually it was negative. Actually CD15 most of the Hodgkin also it does not help in the most of the cases CD15 coming negative. So it was negative in
Correct. So CD15 is quite an outdated marker. I don't even put it in my Hodgkin
we
lymphoma.
also don't put
Correct. And it stains myeloid. It's very non-specific. It stains a lot of other cells as well. Then somebody has written, what about GATA3? GATA3, I mean, I don't really understand the significance of GATA3 in this case.
here.
Dr. Lakshmi?
I talked to sir also. As far as the treatment of the patient is concerned, NLPHL means in the clinical setup they are treated by both RSOP and ABBD. NLPHL
Yes.
in case of NLPHL,
Especially if 20 positivity comes.
So in this case, the patient was treated by RABBD. So
You're right, Dr. Arun. Extensive 20 positivity becomes a ground for giving rituximab to these patients, and they respond much better with that. Somebody has written OCT2 is also positive, correct? So we can see one of the transcription factors positivity, either OCT2 or BOB1, but usually one is lost in case of a classical Hodgkin's lymphoma, whereas in NLPHL, you will see both of them positive. Dr. Arun, another question is, can treatment change the immunophenotype?
Yeah, rituximab, post-rituximab can change the phenotypic expression of the B cells, but here there was only radiotherapy. There was no chemotherapy before excision of the lymph nodes. There was a history of only radiotherapy. So,
and as Sunita ma'am has also said, you can, I mean, there is a change in immunophenotype that happens sometimes after treatment, but mostly, you could actually see transformations in these cases, especially cases which show a lot of relapses. So one has to be careful about that. Well, I think we've answered these questions. So let us
Sir,
go on to our...
sorry for the interruption. I'm Dr. Lakshmi here from Trivandrum.
Yes, Dr. Lakshmi.
Sir, actually, I was the one who asked the question regarding GATA3 positivity, right? So actually, in Tata, we used to do GATA as a classic panel. My consultant used to do it on all Hodgkin's lymphomas, and we had seen positivity, nuclear positivity.
See,
so that would be a
GATA3
great, that would be a nice marker too.
I'll just come in now because we can go on discussing this. GATA3 shows positivity in a lot of other cases, including PTCL, where it has now become a, you subtype PTCLs based on GATA3 positivity. And, Hodgkin's and T-cell lymphomas can sometimes, including 30 positivity is seen in PTCLs. So they can actually be very, very confusing. Our main purpose here was to differentiate Hodgkin's classical from NLPHL. So GATA3 won't really have helped in the panel. I think that's why none of us really bothered.
Yeah, it's actually more of an adjunctive marker, but yeah, it does come as positive in CHLs. I mean, classic Hodgkin's.
Okay.
That's why that was my question. Nothing else. Thank you, sir.
So I think basically we didn't put it because we didn't really feel the necessity to help in our cause of differentials between NLPHL and CHL. I usually put it more in cases where I'm suspecting a PTCL because it gives us a prognostic subtype difference. With that, I would like to proceed on the second case. It's a case of a 24-year-old female, and this is a very interesting bladder mass biopsy. And Dr. Nupur will be presenting this case. Dr. Nupur, over to you.
Good afternoon, everyone. Ma'am, you'll have to stop screen sharing, I think.
Dr. Nupur, yeah, sure. Okay.
Uh, just a second, please. Yeah, sorry for that. So, can you hear me?
Very well, Dr. Nupur. Please go ahead.
So, this was a case of a 64-year-old lady, and it was an incidentally detected bladder mass. The lady had actually gone to a gynecologist for a uterine prolapse, and she was posted for a hysterectomy. And during the workup, this bladder mass was detected, and she was referred to the urologist. The TURBT was done. On the surgical procedure, the urologist felt that it would either be a TCC or a fibroid or a leiomyoma. What we received were multiple tan brown tissue pieces, which together measured 1.5 centimeters, and the entire tissue was processed in a single block. On HE, we could see a tumor which was mainly infiltrating the deep muscle, and the lamina propria was spared, and the overlying urothelium was absolutely unremarkable. On a higher power, we can see that the tumor is composed of polygonal plump cells arranged in nests, separated by delicate fibrovascular septa. The tumor cells possessed abundant granular eosinophilic cytoplasm and round to oval nuclei. No mitosis was seen. No necrosis was identified. At places, there were rosetoid structures, and the tumor cells were more elongated. And the rich vascularity is pretty appreciable in this image. So, to summarize the biopsy findings, there was a tumor infiltrating the deep muscle with normal overlying urothelium. The cells were polygonal, arranged in nests separated by fibrovascular septa, and possessed abundant granular cytoplasm and round to oval nuclei with no mitosis or necrosis. So, any thoughts till now? Okay, so we'll move on to our immunohistochemistry. We did a pancytokeratin, which was entirely negative. A P63, which was also negative. A CK7 negative. I'm sorry for the bad quality of this image. And a CK20, which was again negative. We can see the umbrella cells positive in this image. GATA3 was diffusely positive in the tumor cells. So GATA3 would be positive in a TCC, in a urothelial carcinoma. We went on with further markers. NSE, positive in the tumor cells. Chromogranin, again positive in the tumor cells. Synaptophysin, diffusely positive. And a S100, which showed weak to moderate positivity. So that's the immunohistochemical findings. The tumor cells negative for pan-CK, CK7, CK20, and P63, and positive for GATA3, synaptophysin, chromogranin, NSE, with a weak to moderate S100 positivity. So it's fairly straightforward, I think. Why we presented this case is because of the rarity of this tumor.
Diagnosis, two people who have given their diagnosis in the chat box.
Yeah, so I can't really see that.
So we have Dr. Praveen Mahajan and Dr. Veena Vanere, both very closely associated, a part of the, Dr. Veena has been with us here, and Dr. Praveen continues to be a part of the Agilus family. They've both called it paraganglioma.
Paraganglioma.
Ma'am has also affirmed.
Yes. So it was very interesting to see a paraganglioma of the urinary bladder, because these are rare lesions accounting for less than 1% of bladder tumors. And they can be found at any age, anywhere in the bladder, but most commonly in the deep muscle.
Yes. So I think it's very interesting, Dr. Nupur, especially with the location, and it's sometimes yes, it was a fairly straight case, but I still feel that it's sometimes important to even discuss what can very commonly be seen, and it was a very nice case, especially given the location, and I don't think most of the pathologists here had problems in diagnosing it. So, kudos to you for a good presentation. I don't see that there are any questions pertaining to this case. Also, for everyone, I would like to just share that, okay, somebody has asked, was the patient screened for any syndromic association?
No, the patient did not have any other associations. It was just a solitary incidental finding.
Okay.
Also,
And
with any other syndromic associations, the patient may have other clinical features such as a positive urinary VMA, hematuria, maturation attack, but there was no other symptom in this patient.
that's correct. Okay. Thank you, Dr. Nupur. I think it was a very crisp presentation. And for everyone who is attending this talk, please feel free to write your diagnosis while the presentation is going on, or whatever thoughts you have and questions in the chat box. So with that, we move on to our next case. This case will be presented by Dr. Lakshmi from DDRC. And this is another very interesting case of a 65-year-old female patient who presented with abdominal dull aching pain since 2 to 3 days. And USG shows a fibroid in POD measuring 7.9 centimeters in diameter. Dr. Lakshmi, over to you for further discussions.
Good morning to all. Oh, I'm sorry, I've gone to my. Yeah. Can everybody see the presentation?
Yes.
Yes.
Yeah. Yeah.
You may want to make it full screen.
Yeah.
Yes, madam, I'll do that. Madam, is it clear now?
Perfect.
Yes, madam. So this is my case. So it is sir has already given the introduction. It is a 65-year-old female, so postmenopausal and complains of dull pain. And there was a mass per abdomen noticed like 2 weeks ago. And on CECT, there was a large fibroid measuring 6.4 centimeter up reaching up to the level of umbilicus as per CECT. In gross, madam, I received a separately lying grayish-white encapsulated mass measuring 15.5 centimeter in diameter. So its cut section was grayish-white and lobulated and homogeneous in consistency. This was the gross image I have affixed it. And microscopically, madam, the uterus just showed benign endometrial polyp and atrophic endometrium. One ovary showed an endometriotic cyst. The tubes were unremarkable. However, this mass, there was a well-circumscribed neoplasm comprising of cells arranged in tubular pattern predominantly. It was also arranged in nests, incisal and trabecular pattern, a very fibrous stroma. And there were very bright eosinophilic secretions in many of the tubules. And these individual, this is the low power picture, madam. This is the 40x picture of the same. You can see this. So it had a very, different look to it. And these individual cells were having a cuboidal look with very uniformly placed, and they had pale, evenly dispersed chromatin. So these are the pictures on 100x. And this is a very, the close-up view of that one of the tubules which I had seen. And immunohistochemistry, it was immunohistochemistry was CD10 positive, madam. It was CK11 positive. CK5 was positive in the squamous elements. Then CK7 is positive. CK19 came positive. ER came strong positive. AR was negative. CK20 was negative. PAX8 was negative. WT1 negative. GATA3 negative. Inhibin negative. Mammoglobin came positive. And even CDX2 and PR had come positive. And TTF1, SADB2, CD19 and CA have come negative. So what is your diagnosis? I mean, anybody's brainstorming around? Sirs, ma'am.
Endometrial stromal sarcoma with extensive glandular differentiation.
Okay. Actually, it turned out to be a Wolffian tumor or a female adnexal tumor of probable Wolffian origin.
Okay.
This is a very, very rare tumor. It has a very wide range.
Other people who have, also ventured to give their thoughts. We have Dr.
Wow,
Divya, who's
awesome.
called it endometrial stromal sarcoma. We have Dr. Malini, who's called it FATWO. We have Dr. Supriya Jain, who's called it mesonephric remnant.
Yeah. Yeah, wow, very nice. But actually, everybody has come closer around because this tumor actually arises from the mesonephric remnants, madam. But actually, it has a very wide age range with 15 to 87 years. It has a very, it's mostly occurs in a broad ligament because that is what the doctor had told me intraoperatively, that mass was in the broad ligament. And it's mostly, it can present very incidentally, and there can be non-specific symptoms around with it. And these tumors can vary in size from 1 centimeter to 30 centimeters in size. And there are very, very rare cases. That is, it's, I've seen one paper in which they have presented 11 cases in a capitals have presented it. I mean, you can even check out the paper. I'll pass down the reference. And they've done a detailed examination of this case. So in this can show a variety of patterns. And the peculiarity of this tumor is that it can resemble adenocarcinoma as well as it can resemble a sex cord stromal tumor and even ESS. So it has a very wide differential and it comes, it takes both the markers, the cytokeratins as well as your sex cord stromal tumor markers variably. So the thing that can differentiate it from the remaining CD10 is a very good marker in this case, which can come. And malignancy also can occur in this tumor when there's high cellularity, pleomorphic nuclear, increased mitosis.
Okay. Thank you, Dr. Lakshmi. That was a really, really interesting case. We have a few questions for you. Dr.
Yes, sir.
Arijit has asked any CT findings in such cases.
CT findings are just non-specific actually. They just present as a broad ligament mass. So they might turn out to be like a fibroid. I exactly don't know the radiological details, but they can look like a fibroid as my case.
Then Dr. Bipasa Chatterjee has asked, did you see mitosis in it?
No, madam. Actually, I only saw 0 to 1 mitosis for 10 high power field, madam. And it was very, very occasional. I had taken like 7 to 8 sections. And on extensively searching, I only got 0 to 1 mitosis per 10 high power field.
Okay, so I think this is quite an interesting case. With very, very close differentials. Abha ma'am, any thoughts from your side?
Interesting case, very interesting case, and
Thank you, madam.
very well presented.
Thank
The
you so much,
inputs
madam.
too were very good.
Thank you,
madam.
Dr.
Thank
Lakshmi.
you so much.
It also makes us aware of this entity, especially when we, as Sunita ma'am had said, ESS with glandular elements is something that can look quite like this. So we need to understand that there is an entity like this, which we need to very carefully rule out. With that,
Thank you for your
I think we
inputs,
can
madam.
proceed to our next case. This will be
Thank you so much.
from our city of Kolkata. Dr. Saurav will be presenting this case of a 45-year-old male patient, a known case of monoclonal gammopathy, M band present, 0.09 gram per DL. Then IgA kappa has been detected on immunofixation electrophoresis. And what he got was bone marrow biopsy and retroperitoneal lymph node core biopsy for evaluation. Another node and bone marrow, and very, very interesting case. I've seen it. Dr. Saurav, over to you.
Yeah, thank you, Dr. Kunal, for the nice introduction. And is the slides are visible and am I audible now?
Dr. Saurav, we could just increase your volume a little.
Am I audible now?
Very well.
And the slides are visible? Okay. Let's proceed to the case for today. And just a minute. Okay. Is the slides visible now? Hope. And it's moving.
Yes, Dr. Saurav, please go ahead.
Okay. Oh, so this was a 45-year-old male, and the patient. This is quite a tricky to diagnose case and the unusual presentation. Otherwise, the diagnosis is the straightforward. And the patient was a 45-year-old male, and that patient presented to the urology department with a suspected urethral stricture. And that guy was admitted under a urologist, and they tried for urethral dilatation, but that failed. And subsequently, the patient developed fever with dysuria, chills are there, and there was some both lower limbs weakness, tingling and numbness of the limbs. And so that clinician asked for the neurology review. The neurologist checked the patient and they advised for some CSS study, but CSS study was the cytology was within normal range, and no malignant cell was there, and gene expert for MTB and DFAS was also sent, but that was also came to be negative. But one finding was there was presence of albuminocytological dissociation, and MRI brain and LS spine was okay, and no finding was there. And in non-conduction study, they find that this is a case of demyelinating sensorimotor polyneuropathy or GD syndrome. But so the neurologist advised to take the IVIG, but the patient relatives refused to take that, and so the patient was put on steroid, and the patient got symptomatically better with the steroid. And on the other routine investigations, it was found that there was a presence of pancytopenia in the peripheral blood smear. And in biochemistry, there was a high ferritin with mildly high triglyceride and raised marker for sepsis. And USG and CT abdomen was done, and that revealed the presence of hepatosplenomegaly and multiple retroperitoneal lymph nodes. So the patient was also referred to the hematology and gastroenterology for the work of anemia. And in anemia evaluation, no GI bleed was found, and serum protein electrophoresis with immunofixation electrophoresis was done, and M band came to be positive with a very low count of 0.09 gram per DL, and on IFE it was found to be a IgA kappa. And so the hematologist advised for the bone marrow biopsy, and unfortunately the patient undergo directly for the bone marrow biopsy without doing the bone marrow aspiration. And with a probable DDs in mind, keeping that it might be a case of plasma cell myeloma, or keeping in mind of the high ferritin or mild TG high, there it is a case of HLH or urosepsis. So coming to the morphology of the bone marrow biopsy, what we have got that the marrows looked quite cellular, and as per the age of the patient, and in some fields there was some looking epithelioid looking cells are there with some kind of ill-formed organization. So we are in doubt of whether we are seeing dealing with any cause of granuloma or not, or whether there is any myelofibrosis or not. So in the bone marrow trophine biopsy finding, it's a cellular marrow with some periepithelial cell granulomas or fibrosis, or we are missing some kind of multiple myeloma with spindle cell presentation of plasma cells. So we went for reticulin stain, and reticulin stain fibrosis was around grade 3, and CD130 it was positive. It highlighted the plasma cells, but they were not so much high, and they both expressed the kappa and lambda markers. So there is a polyclonal population of plasma cells, and so it still remained inconclusive and clueless. And then, so we asked for the retroperitoneal lymph node sampling to the clinician. And retroperitoneal lymph node TrueCut biopsy was done. And again, this lymph node biopsy is quite cellular, and with the effacement of the lymph node architecture was there, and some focus so some from granulomatous areas, and some kind of large cells were there. So coming to the hyper picture of that large cells, and we can see that some cells with a eosinophilic cytoplasm with irregular lobulated nuclei and prominent large eosinophilic nuclei was there. So we put on the ICs, and I see the background lymphocytes, so the both expression of CD3 and CD20, and the large cells show strong expression of CD30 and somewhat a bit moderate expression of X5. And Ki67 was around in the range of 50 to 55%. Then, so it is now quite clear that we are dealing with a case of possibly classic Hodgkin lymphoma. And then we again review the bone marrow biopsy slides and whether we have missed something or not. In careful search, we got some focus with some high eosinophil count was there, but not more than that. And but in single focus, we found a single cell which looks like a possible RSLs. It might be with a prominent large eosinophilic nucleoli. And we also put on the IHC over the bone marrow biopsy. And then again, the background lymphoid cells show the mixed expression of CD3 and 20, and CD30 took up the large cells. That quite a few was highlighted by the immunohistochemistry then. And PAX5 also show weak to moderate positivity. So the diagnosis of this patient came out as a classic Hodgkin lymphoma in retroperitoneal lymph node, along with infiltration into bone marrow trophine biopsy in a case of demyelinating polyneuropathy with uropathy and monoclonal gammopathy. So there is a very few case reports where there is the association of polyneuropathy with lymphoma, but most of them is were with the non-Hodgkin lymphoma, but a single case report was there where the in Hodgkin lymphoma subsequently developed polyneuropathy, and few case reports show that Hodgkin lymphoma is a complex paraneoplastic neurological syndrome they have presented. The possible causes of Hodgkin with neuropathy is due to the might be the Hodgkin paraprotein or some neurolymphomatosis, or some due to paraneoplastic syndrome due to antibody against the tumor antigen, which targets the neural antigens. And association of Hodgkin with urological symptoms is also very rare, and these are the mostly with the obstructive symptoms due to the obstruction of the urinary tract by the large retroviral nodes. And association of Hodgkin with gammopathies is also very rare, and most of the gammopathy with lymphoma is by the lymphoplasmatic lymphomas. And Hodgkin with multiple myeloma is quite a few cases, but Hodgkin with MGUS is still further rare. Possibly IL-6 related some causes are is in the hypothetical stage, and they are suggesting that possibly IL-6 might be a cause behind the relation of Hodgkin with MGUS. So this is a very unusual presentation of the patient, and with some other paraneoplastic or some comorbidities, and this was very tricky to diagnose this case. Thank you.
Thank you, Dr. Saurav. I think this was a very, very interesting case, and it represents how Hodgkin's and how hematolymphoid neoplasms can sometimes present with a different clinical picture, where we don't really suspect a Hodgkin's lymphoma like in this case. So extremely, extremely good case, and very well worked up. Also, what was important was how you asked for a lymph node biopsy, because sometimes in a marrow, when you have very few RS cells, it can be very, very tricky. A good pointer I feel is the milieu that you sometimes get to see, even in the marrow, but it could still be tricky because the RS cells don't exactly look like RS in a marrow sometimes, and you have these monolobated immature megakaryocytes which can sometimes look pretty overlapping with RS. Thank you so much, and I think we have many good feedbacks for this case. Dr. Alka has asked, any genetic component was done?
No, actually, we didn't work up any genetic workup was there, but the patient was shifted to the other Oncopathology center, higher center, with the site and blocks they have taken away, and so further workup and could not be possible in this case.
But extremely very good case. Ava ma'am, your thoughts?
No, I was just wondering if we have any clinical follow-up.
Ma'am, the clinician was constantly in touch with us, and the clue was that the clinician has given steroid, and in the primary, when we got the bone marrow different biopsies in the granulomas, we thought whether we were missing any tuberculosis or not. The clinician constantly stated that if they are given steroid, the patient is responding. If it is TB, then the patient should not be responded. And so we again we look after the slides and ask for the retroviral lymph node biopsy, and which brings the diagnosis.
When in 1985, the first time Hodgkin involvement of the marrow was defined, those days, I have learned my lymphomas by Luke Collins classification, working formulation, then I learned the real classification, and now this, I've gone through the whole spectrum. So the first time the bone marrow involvement of Hodgkin was very well defined. They said how to report the bone marrow involvement by Hodgkin lymphoma. So that is the first time they said that, first is the two categories, proven Hodgkin, and then you're doing marrow. So what are the features that will define that the marrow is involved by Hodgkin? And in those, the granuloma, if you find in a known case of Hodgkin, and you prove that there is no infective organism responsible for granuloma, then it is involved by Hodgkin. And in India, when we granulomas are very strongly associated even in lymph nodes, and but we have this, we are endemic for TB. So very often the patient gets treatment for TB and the background of the lymph node is ignored. So whenever you get a TB diagnosis and a lymph node for TB, then you must also pay some attention to the background of the lymph node, because if you possibly will miss Hodgkin's if you don't look at the background. And many times, so when I learned in 85, 86, anytime you see granuloma, you must treat for TB, irrespective what it has, whether it is associated with metastasis or whether it is associated with lymphoma. But now, at least we are not doing that. If you have because once you diagnose TB with the malignancy, you have to delay the treatment.
Right.
So-
Excellent points. Excellent points, Sunita.
Okay.
Ma'am, we'll go over to the next case now. All right.
Please.
So this is one of my favorite cases. We have presented this in Mumbai, surgical senior surgical meeting as well, and this is a case which where IHC will definitely be the clincher, and nobody could diagnose it there at the senior surgical. And without taking away the thunder from Dr. Priyanka, I will just share the clinical presentation. This was a 55-year-old male patient of East African origin. This is a HIV positive patient who presented with generalized lymphadenopathy and a large 8 centimeter intra-abdominal mass. With that, Dr. Priyanka, over to you.
So Kunal has challenged us. He said no one could diagnose it in the senior surgical at Mumbai. So everyone put on your thinking caps.
I'll also give another hint. It was very often misdiagnosed as another entity, which is very similar. Farasat bhai, if you can just share the case, because there is some problem in Mac screen sharing for Dr. Priyanka.
All right, all right. So,
Or should we move on to the next case? Meanwhile,
Ma'am, if he can, it'll be fine. Otherwise, I'll move on.
okay, just a moment. So,
This is case number 5.
had she sent to me because I have
Yes. I have mailed you, sir.
okay. Priyanka, right?
Yeah.
Just a moment. I'll do it quickly. So I had responded to you. This is some other file which is not opening on my system. It is dot key extension. So I had responded to you. Sorry, I didn't. I
So
forgot.
what we'll do is, ma'am, I'll move on to the next case. In the meantime, we have our section manager. He will put it in my computer and Priyanka can present after me, right? Okay. So
next case is Gopendra.
mine. I'm presenting it.
Okay.
Can you see my screen?
Yes. Just
Okay.
make it full screen.
1 second, ma'am. I'll just do it. Okay, so this is also a very interesting case. We got this from our friends in Mahavir Cancer Hospital in Patna, and this had multiple diagnoses, as I will share with you. This was a case of a 60-year-old male patient who presented with occipital swellings in 6 months, and CT scan showed a soft tissue mass measuring 5.2 into 4.5 centimeters in the occipital region in the midline, with extension into adjacent scalp, bone, and dura. So this shows that this was a clinically and pathologically aggressive disease, and dura with mild indentation over the cerebellar hemispheres. On histomorphology, if you see this, on a lower power, this did not look very, very, aggressive or very dangerous looking, but it did look like something that could be mesenchymal, could be epithelioid. And when we went a little higher, we could see these really closely packed cells. Some of these were, ovoid to short spindled in shape. And you could then, on the higher power, you could actually appreciate pretty conspicuous anisonucleosis and nuclear pleomorphism. But as you can see that some of these cells, they still continue to look very epithelioid. So I was, keeping both my options open. I actually also was keeping an option open for a hematolymphoid malignancy in this case. This is the higher picture, the higher power picture. So if you see here, you can see that these cells are epithelioid to ovoid. Some of them are very, they are stout and shortly spindled. And in this picture, you can actually see atypical mitotic figures. There is one that, I've tried to show, which has spicules almost. So this did show brisk mitotic activity in alignment with the clinical picture of this being a very aggressive neoplasm. There is another thing which was very striking for me in this case. That was what I'm showing here. If there is anybody who can point it out, you please feel free to write it in the chat box. But remember this picture and we'll come back to it later. So your opinions in the chat box, please feel free to write whatever is your differential diagnosis based on this. Are you open for, an epithelial neoplasm, open for a mesenchymal neoplasm, open for a hematolymphoid neoplasm, and open for even a melanoma in this case, an amelanotic melanoma, although we didn't see any melanin pigment deposition. So you can continue to write. I'll just share the primary IHC panel that we did. So interestingly, this case was positive for pan-CK and it was positive for P63. And one of the primary differential diagnoses which I had from another laboratory was a sarcomatoid carcinoma. So have we made the diagnosis? Looks like sarcomatoid carcinoma. Yes, it does. And should we stop on these IHC markers? I usually tend not to. So, we went ahead and did a few more markers. Vimentin was also focally positive, and actually it was quite positive in about 70-80% of the cells, and SMA was positive. Probably still sarcomatoid carcinoma or something else. Then we did our Ki67 index, and Ki was extremely high grade in alignment with a malignant neoplasm. And INI1 showed retained, nuclear retention. So INI1 was retained in this case. We were also thinking of an epithelioid sarcoma kind of a picture, but INI1 came retained. Okay. 1 second. Somebody has said nut. That's a good thought. So this was the other extended panel which I did. HMB 45 was negative, 45 was negative, 31 was negative, EMA was negative, CD31 was negative. So no vascular tumor here. We are not dealing with a case of, epithelioid angiosarcoma. TTF1 was negative, CD117 was negative, and KX3.1 was negative. We still did it because this was a male patient. 720 negative. We must always do 720 once our CK comes positive. Desmin negative, S100 negative, Napsin negative, ERG negative. So nothing in vascular. Then I decided to do certain markers, which were CD34 and STAT6. I think somebody in the chat box did mention about staghorn vessels. And yes, you are right. That is what made me think about doing these markers. And as you can see, both CD34 and STAT6 were diffusely positive. So the diagnosis now is pretty clear that we are dealing with a case of malignant solitary fibrous tumor. Why I really wanted to present this case was that please see that in your initial marker workup, this could very easily have stopped with sarcomatoid carcinoma. The other thing is CK positivity in a SFT is a very, very rare finding. We don't usually see it, but you must always remember that CK can come positive in a case of solitary fibrous tumor. These are just some of the papers that we found out which tell us about CK positivity, and sometimes SFTs can be negative for CD34 also. So if you see 34 negativity, but you are still suspecting SFT on your morphology, please go ahead and do your STAT6, which is actually a surrogate marker for your NAB STAT6 fusion. Now, the important thing which I want to tell
Why
you
did
here.
you not think of synovial sarc when CK was positive?
Sorry, please come again.
Synovial sarcoma.
Synovial sarcoma, we did not think of it primarily because, CK positivity of this extent plus, the morphology was not very typical. I did not think of it. These cells were looking very epithelioid to me. But epithelioid synovial sarcomas are also there. And thankfully, much before I had to put my BCL2s and TLE1s, I did come up with my diagnosis. So the other thing which I wanted to share with everyone is that whenever a SFT starts turning malignant, it tends to start losing CD34 and it tends to start acquiring CK. So if you are seeing CK positivity and negativity for CD34, okay, and you are seeing negativity for CD34, you are probably dealing with a malignant solitary fibrous tumor. There are certain characteristics which tell that whether SFT is malignant. If you see mitosis of more than 4/10 high power field, if you see, a large, probably more than 10 centimeter in size mass. So if you see a lot of necrosis, so these are things that would probably tell you that this is a malignant counterpart of SFT. So with that, I close my case. Somebody has said, but CD34 is positive in this case. Yes, it can be positive. Not all malignant SFTs will show loss of CD34, but if you see CD34 loss, these are more likely to be malignant, if that answers your question. And any other? Mitosis count was pretty high. It was about 5 to 6/10 high power field. Synovial sarcoma, good differential. We didn't do it. Neuroendocrine. I didn't do the neuroendocrine markers. PNST. Okay. Nut. So you see, once you get your STAT6 positivity and you get your 34 and STAT6 both combined positive, we are pretty clear that we are dealing with a case of solitary fibrous tumor. Dr. Malini has asked a very interesting question. Does P63 come positive in SFT? Dr. Malini, P63 is a marker which I usually put for, misleading my audience. P63 will come positive in everything, including a plasmablastic lymphoma, which I had presented in another senior surgical where, that was basically put for that. And yes, it comes positive in anything from lymphomas to sarcomas to carcinomas. So with that, if there are any more questions, or we will move on to the next case. Any thoughts, Abha ma'am, on this case?
No, let's move on to the next case.
Sure. Okay, so our next case is a case of 40-year-old female patient with nodular lesion on back since 2 to 3 years. And this is a very, very interesting case. This will be presented by our friends at Fortis Vasant Kunj, Dr. Gopendra and Dr. Nitin. Over to you, please.
So, Dr. Kunal, before they present, so Dr. Priyanka's updated PPTs there with me. So after that, we can share the case number 5.
Sure.
Or,
so we'll
or
let
as
Dr.
is.
Gopendra present, and after that, we'll share Dr. Priyanka's case.
Perfect.
Yeah.
Dr. Gopendra, over to you, please.
Dr. Kunal, I think you can stop this screen sharing.
Oh, sorry. Yeah. It's done, right?
Then we can let's share screen. Desktop. Screen share. There's a desktop. Desktop share. ये तो मेल है share click करो. No, it says click. The system is slow. Our system is super slow. Slow system. PowerPoint. 33%. Slow system. Full screen.
Yeah, I think it is visible.
Okay. Huh. All the
Yeah, Dr. Kunal, it is visible.
Yes, yes, please go
Yeah,
ahead.
it's okay. So we are presenting this case number 7. The clinical details is this is 40 years old female, presented with complaint of presence of subcutaneous nodules in the mid side of the back, and it has been 2 to 3 years, and she gave the history of discomfort and pain on touch. On examination, there was no other systemic illness. Her vital was normal, and there was no other associated limb adenopathy. She denied to have any fever or weight loss. So with the clinical diagnosis of dermatofibroma versus lipoma, the patient has been referred to our department for FNSC. FNSC was done from a lesion. So this is the picture, microphotograph. It was cellular. Of course, FNSC is from the lymph node is supposed to be cellular. And if it's not cellular, it's going to be inadequate. So we saw this hits of these lymphoid tissues, which is infiltrating into the fibroadipose tissue. And just going to the higher view, we see most of the cells, they are of small lymphoid cells, and it is mixed with those larger cells and intermediate cells. So in other words, it's a polymorphous population of cells, which we see, and we try to see for any distinguishable body macrophages. Distinguishable body macrophages, this was rare, and we couldn't see much of it. And we see some pigment-laden macrophages are there. And other, we try to see for any abnormal cells. We didn't see much of it. So we give a diagnosis of reactive lymphoid tissue in the dermis, and we inform our clinicians to just get an excision biopsy, since we see some of those, centrocytes and centroblasts which are prominent places. Subsequently, biopsy has been done from that area. In our department, we receive around 1.5 by 1 centimeter, which is skin covered, and the biopsy is showing diffuse infiltration of these lymphoid cells, and the upper part of the biopsy, that is epidermis, it was normal. There was no other infiltration of these lymphoid cells. In other words, there's no epidermal provision. So the lymphoid tissues are infiltrating mainly in the mid dermis as well as the lower dermis. The lymphoid cells are coming in diffuse sheets as well as in the nodular pattern. Again, it is infiltrating quite a lot, mainly in the dermal collagen, splitting most of them, and the dermal collagen get hyalinized at places. High power view of the SAM. The cells are of medium to large. These have got this dispersed chromatin, and most of them are cleave and non-cleave cells, and some of them have got prominent nuclei. I think this is a larger cleave cells, which is non-cleave, centrocytes. And when we try to see for any larger cells or atypical RS cells and others, it was not there. There was no immunoblasts. There was not much of those centroblasts. So again, it is from another area. There is, of course, it was mixed up with those mesio small lymphocytes. So with this, we have got so many differences in our thought that it is either is the reactive lymphoid tissues, which is found in the dermis, or whether this is a primary cutaneous follicular cell lymphoma because the patient doesn't have any lymphadenopathy, or whether this could be secondary cutaneous follicular lymphoma. And the fourth one is cutaneous marginal zone lymphoma and cutaneous mantle cell lymphoma, or it could be primary cutaneous diffuse large lymphoma. So the differences are wide. So in that, we start putting up immunohistochemistry. Now it is seen that CD20 is diffuse positive. which is seen in almost more than 100%, around 100%, of course, it's fully positive in CD20. So I think it's unlikely for the reactive. And CD3 was positive in around 60% of the cells. It has got some moderate with positivities there with moderate intensity, and 60% of the cells are standing that. And we put again CD10 and BCL6, which was diffusely strong positive, which is more now going in favor of this follicular. And let us see furthermore. And we put this CD23, which was negative and is highlighting the follicular dendritic cells in those lymphoid, in those what we call that in the nodular areas. And cyclin D was that negative. It was negative. BCL2, we can say is a focal positivity is there. And MUM1 was also positive. MUM1, basically, we try to see those plasmacytoid or plasmablastic cells. The MUM1 usually stands those lymphoplasmacytic cells, and it is showing in some of the bigger cells. But we won't consider much about because it's not the positivity, the intensity, as well as the percentage is less. KIC7, of course, was supposed to be done in almost every lymphomas. We thought on a line of lymphomas, so KIC7 comes out to be around 30%. So to summarize, this is clusters or aggregates of atypical lymphoid cells, which is found mainly in the lower dermis, which is infiltrating partly the surface tissue. It is composed of the mixture of large non-cleave as well as small cleave cells, which in the background of small mesolymphocytes. And there is one good point that there's no epidermotrophism. And the cells are CD20 positive, 10 positive, BCL6 diffuse positive, and BCL2 focally positive. And they are negative for CD3, CD23, cyclin D1, and MUM1 was focally positive. And with the KIC7 around 30%, we conclude that our diagnosis is likely to be of primary cutaneous follicular cell lymphoma. However, we write this, just to rule out for the secondary follicular lymphoma, the patient is supposed to be worked up with all those PET scan and others. So we give the diagnosis as primary cutaneous follicular cell lymphoma. Now, Dr. Nitin will be doing some review of literature in this case.
Now coming to the cutaneous lymphomas as such, we have to divide them like a conventional lymphomas into T cell and B cell. As everyone is aware, T cell lymphomas are more common in the skin, primarily being mycosis fungoides. Now the annual incidence rate of a cutaneous lymphoma is very low. It's only 0.3 per lakh. And mainly, as I mentioned, they are arising from the T cells, 65% of them, 25 are of B cell origin, 10% are histiocytic origin, and there may be some other rare type of lymphomas. And now lymphomas which arise from the B cells, most common are these follicular center cell lymphomas. And these are also included in the revised WHO classification, that is the 2016 latest. And why? Because it has a bearing on the prognosis, they have a good prognosis. And they are more common in the middle-aged population. Pathophysiology, there are varied pathophysiologies. Some people say there is stimulation of organisms which cause chronic infections, mainly Borrelia and EBV. Clinically, they can present as a nodular lesion, as a plaque lesion. They may ulcerate or may not. More common in the head, neck, and trunk. Our patient had a nodular type of lesions, and these were grouped. I had done the FNAC. There were 2 lesions on the mid back. So they were group lesions, but there was no ulceration. Main is how do we distinguish it on histology from a primary follicular lymphoma is when similarly we'll be seeing either a follicular pattern, a nodular, or a diffuse pattern. But here, like centrocytes and centroblasts, we will be seeing those as illustrated by Dr. Gopendra in the image. But here we don't grade the lesion. Like in a follicular lymphoma, we do it grade 1, 2, and 3 based upon the presence of centrocytes and centroblasts. That doesn't have a bearing on the prognosis here. And more important is going to the cytogenetics, a 14-18 translocation will be absent in these cases. In our case, it was not done anyhow. And the prognosis, as I mentioned, it is an indolent disease. 5-year survival rates are very good, up to 98%. Treatment-wise, radiotherapy is offered in case of lesions which are restricted to a single area, as was in our case. And rightly so, radiotherapy was offered to the patient, and as feedback from the medical oncologist, the patient is now doing well. There are no extracutaneous manifestations and no constitutional symptoms are there. But sometimes they offer an R-CHOP. That is whenever there is a multifocal involvement of the lesion where there is extensive skin disease or there is ulceration, which was absent in our case. Thank you.
Yeah, in such cases, even if we don't treat, basically they may be multifocal or they may be lying in a single area. They hardly match or they hardly go to other part of the body. This is pretty good, having pretty good prognosis.
There are a few questions. I think somebody has written if they wanted to see BCL2 again, but I think Dr. Jofi has answered it very well. I will believe if you said BCL2 was positive, but people should know that BCL2 negative follicular lymphomas also exist. IGH BCL2 translocation might not always be seen. And the other thing is, another very, very important fact is that not always a follicular lymphoma will show you a follicular pattern. We need to understand that there could be a mix of follicular and diffuse patterns. There could be diffuse patterns of follicular lymphoma, and they are not characterized as DLBCLs. I mean, a more aggressive biology versus patterns, these are different things. And grading is a completely separate entity, which will depend upon the number of centroblasts which are present or not. So I think with that, we will move on to our next case. This is Dr. Priyanka's case, and I will hand over the platform to her. I have told the diagnosis to some people, so they should not, their coming in will not be counted, but, over to Priyanka.
Yeah. I'm sharing my screen. What?
Yeah.
Can everyone see the screen?
Yes, we can see. We can see, and you can make it in presentation mode.
This was a 55-year-old male of East African origin. Patient was HIV positive and presented with generalized lymphadenopathy and a large 8 centimeter intra-abdominal mass. We got paraffin blocks for review. Okay. Second. So this is the HE slide where at one end where you can see the normal colonic mucosa, and in the subserosal layer we can see a tumor which is arranged in diffuse sheets. It's a blue looking tumor. On higher power we can see that there is a little bit of rosetoid arrangement, and the cells are large, with some of them having plasmacytoid-like morphology with eccentrically placed nuclei and a perinuclear HOF also at here. Yeah, here you can see some perinuclear HOF. So, any opinion? Yeah. After HE, what differentials can you think of? Okay, there are some chat coming up. So the differentials which I thought about was a carcinoma with plasmacytoid morphology, since it was in the abdomen. Then also I thought about plasmablastic lymphoma, an ALK positive large B-cell lymphoma, a DLBCL with CD30 positive, an ALCL, and obviously a plasma cell myeloma. So we did a first panel of markers where CD45 was positive, patchily positive. CD3 and CD20 both were negative. This was also shared with the presenter link. So a hint was given. And Ki67 was very high. It was 80 to 90%. Let's move on. And yes, pan-CK was negative. Now, we also did some more B markers like PAX5 and CD79 alpha, and both were negative. T cell markers like CD5, CD2, CD7 were negative. Even TDT was negative. Then we moved on and we did CD38, which was weakly positive. MUM1 was strong and diffuse. CD30 was positive, and ALK1 was negative. CD56 and EMA were negative. So any more?
So basically, you have a case where pan-CK is negative.
Yes.
45 is very, very weak in focal in places. Both B and T markers are negative, and what we are getting positive is 30, MUM1 and plasmacytoid marker, which is 30 and 31.
Let's move on. We did OCT2 and BOB1. OCT2 was negative and BOB1 was diffusely positive. We also did light chain restriction markers where kappa was negative, lambda was weakly positive. And then we did Eberish. And Eberish came out to be negative.
At this juncture, if there are any, people have asked for Eberish, so whatever are your thoughts, please feel free to put them.
Yes. Plasmablastic
lymphoma seems like.
Yeah, many people have answered
When you're right,
plasmablastic.
it looks like that.
Yeah, but Eberish is negative. So
which can be seen, not mostly Eberish.
Yes. So we did one more marker, which came out to be diffusely and strongly positive, and that was. Second.
Okay, so this was the diagnostic clincher.
Which was HHV8, which was diffusely and strongly positive. And so our final diagnosis, and also, we did IgM, which was also positive. And our final diagnosis was HHV8 related diffuse large B cell lymphoma, NOS. So let's come and see what all comes under the HHV8 associated lymphoproliferative neoplasms. So we have HHV8 positive multicentric Castleman's disease, we have HHV8 positive DLBCL and HHV8 positive germinotropic lymphoproliferative disorders. We also have primary effusion lymphomas which come positive for HHV8 with cavitatory and extracavitatory variants. And if we see in this, I have just made a table where you can differentiate all these entities, where we see that where we see that in HHV8 multicentric Castleman's disease, there are abnormal follicles and there are presence of plasmablasts predominantly in the mantle zone and in the interfollicular plasma, and there is interfollicular plasma cell hyperplasia. And in HHV8 positive DLBCL, there is sheets of large plasmablastic cells. And in HHV8 positive GLPDs, there are plasmablasts within the germinal centers. And HHV8 is like positive in all the cases. Eberish is negative in the HHV8 positive DLBCLs and the multicentric Castleman's disease. And in primary effusion lymphomas, both HHV8 and Eberish comes positive, and most of them have a poor prognosis. Only the multicentric Castleman's disease have poor prognosis, but they have the prognosis is improved with some newer therapies, and the GLPDs usually respond to treatment. This was a very nice article which I got where the IHC markers were elaborated nicely. So thank you. Are there any questions or?
Let's see the chat box.
I think.
Ava ma'am, Sunita ma'am, any comments?
How did you think of doing HHV8?
Ma'am, since this case was received from Africa, and since Eberish came negative, this was actually worked up with, Dr. Vishaka also worked this case up with me. And we were thinking about a plasmablastic lymphoma only. We were like, this can be a plasmablastic lymphoma, and there are rare cases of Eberish negative plasmablastic lymphomas as well. But in the literature and also in the WHO, it's written that if you want to report a case of a Eberish negative plasmablastic lymphoma, HHV8 should be also negative. And since it was an African patient with HIV positive, we thought that this marker should be done. And and we did it, and it came positive.
For the just like to say that in cases of African patients with HIV positivity, no matter what the age group is, plasmablastic lymphomas and HHV8 positive lymphomas, what we need to understand is HHV8 positive, these are B-cell lymphomas.
Come close, can't hear you.
Can you hear me now?
Yes.
Better, better.
Just for the house, what I wanted to share was that for African ethnicities, especially HIV positivity, Burkitt's, plasmablastic, and HHV positive DLBCLs are three that we should always work on. An issue with HHV positive lymphomas, B-cell lymphomas, is that these will usually be negative for B-cell markers and they will show positivity for plasma cell markers. So very likely to be confused with plasmablastic lymphomas, especially Iber-rich negative cases, because they are tricky. We need to know that Iber-rich negativity can also be seen in plasmablastic lymphomas. That's why we thought of doing HHV.
Very interesting case. Very interesting case. Someone has asked the significance of rosettes. First slide.
There is no significance as such. I just mentioned it since it was seen in our case, and that was actually we thought about a carcinoma or any other
So, Dr.
tumor with rosette.
The thing is that this kind of morphology, as you rightly said, is seen in HHV positive lymphomas. Plus, we need to be careful because this is also seen in a lot of other, as Dr. Priyanka said, morphological mimickers. You can have other mesenchymal neoplasms, especially with your 45 being only focal.
Closer, can't hear you.
Sorry, ma'am, what I wanted to say is that yes, we can see rosettes in HHV positive lymphomas. So that is one of the reasons why we showed them. The other reason is that these also need to be, we need to be careful that this is not any other neoplasm, especially mesenchymal neoplasms, because 45 was very focal and scanty. And we will get Vimentin positivity in these cases. 99 can also come. So you can, they can probably take us towards your mixed family of tumors. So that's one of the reasons why we wanted to show that it can happen here.
Right. Should we move on to the last case?
Absolutely, ma'am.
So,
ma'am, we have
so interesting that we've got lost in them.
I know we have two more cases actually. We'll just ask the presenters to be a little careful about the timings. Our next case is Pooja. She is from our Dr. Fatke's lab, and Dr. Pooja will be presenting a very interesting case of a 43-year-old female patient who with an axillary lymph node biopsy, clinically suspected to be tuberculosis or lymphoma. Dr. Pooja, over to you. We have to stop screen share.
Yeah. Good afternoon, everybody. I'll just share my screen.
Yeah, Dr. Pooja, you are audible.
Yeah. Am I audible and is the screen visible?
Yeah, your screen is visible. You can put it into presentation mode.
Yeah. All right. This was a case of a 45-year-old male who presented with some axillary nodes.
So, Dr. Pooja, you can, sorry for the interruption. You can put your presentation on slideshow mode, please.
Yeah. So this was a, sorry for that, 43-year-old male who had presented with some right axillary nodes. And clinically, the clinician was suspecting a very broad thing, either tuberculosis or lymphoma. So when we received the gross, we received it as multiple gray white pieces aggregating to quite a big chunk, about 18 by 12 centimeters. And we dissected on multiple nodes from that, ranging right from 2.5 to the largest, measuring about 9 centimeters. And the cut surface of the nodes was solid and gray white. So we can see here one of the nodes. We can see that on low part, it's got a diffuse sheet-like pattern. The usual nodularity is not seen. There are some pale nodular areas at the periphery and some tumor pale area that it could be a lymphoma, lymphoid proliferation. And the paler areas, when we saw, these paler areas were actually showing few granulomas. So there are few granulomas, and then there is a larger area of sheet-like cells. So here we can see at a little higher power that there is this background of these small lymphocytes, and dispersed somewhere in between are these larger cells, which are more clearly seen here. A few larger cells with prominent nuclei and moderate amount of cytoplasm. And the same thing as most of them having single prominent nuclei, some having even two prominent nucleoli. So anybody for any opinions after having a look at this? Dr. Kunal, anybody put anything in the chat box?
Dr. Pooja, we have classical Hodgkin's lymphoma as
Okay.
one of the differentials.
Okay, all right. So yeah, I'll just give the immunos. So we did a CD30 and a 15. They were both negative in the large cells. The large cells were positive for OP2. And when we did a CD20, apart from the B lymphocytes, these cells were also positive for CD20. We did a T-cell marker, so we saw that the background picked up CD3 very well, and these T cells were also positive for CD1. So it was basically having a T-cell rich background. And CD23 just highlighted the dendritic cells, and IgD highlighted a few of the scant B cells present in the background. So anybody would want to comment on what they think could be this case?
There are comments flowing in calling it NLPHL now.
Okay, yeah, all right. So this is basically an NLPHL with a T-cell rich background. The only thing that I wanted to highlight about this case was, one is that NLPHL can come with 6 different patterns. And in our case, it was the diffuse T-cell rich pattern that we showed. The thing about this is that the first 2 patterns have a better prognosis compared to the other 4 patterns. And the differentials that one could think of when they are finding a T-cell rich background and showing, large big lymphoid cells, one is you can have a T-cell rich B-cell lymphoma, a classical Hodgkin's lymphoma with a T-cell rich background, or a nodular lymphocyte predominant Hodgkin's lymphoma with a T-cell rich background. So I think number of previous cases of NLPHL and CHL, all of the immunos have been discussed. The only thing that I would like to bring to light is that when you look at the background of the T cells, in a T-cell rich B-cell lymphoma, usually they are CD3, CD5, 8, and TIA positive, so they are cytotoxic T cells. In a Hodgkin's lymphoma, usually they are the CD4 positive T cells that predominate. And in a T-cell rich NLPHL, they are of the T follicular helper type of T cells. So the thing is, when we look at a relationship between a T-cell or a histiocyte rich B-cell lymphoma and a NLPHL with this, so the classical NLPHL has a more indolent clinical course when compared to a T-cell or a histiocyte rich large B-cell lymphoma. And cases of NLPHLs have been seen to transform into that. So these cases of NLPHL with a diffuse T-cell rich or a T-cell rich large B-cell like pattern behaves less aggressively as a T-cell rich large B-cell lymphoma. And there is evidence that is there to suggest that they might actually represent different spectrums of the same pathology. Because the neoplastic, the B cells have a similar immunophenotyping profile, as well as gene expression profiling has shown no clear distinct gene expression pattern between the two. And they have also found that REL locus aberrations are commonly seen in both of them. And the last thing I'd like to highlight is the microenvironment of this. The disease might have, might suggest the way the tumor behaves, or it's the way it is, because in these cells we have CD4 positive cells are less frequent in a large B-cell lymphoma with that as compared to a NLPHL. Yeah, thank you.
So my question is, Dr. Pooja, you said the initial specimen was about 18 centimeter size.
Yes.
Out of
Yes,
which
that's
you
it.
dig out how many nodes?
So we got quite a few nodes. I would say we got about the largest one, like I said, was 9 centimeters, and the smaller nodes, I think she got maybe about 5, 6 nodes. The thing was
multiple nodes. How old was
Yes.
this patient? How old? I'm
43,
sorry,
43-year-old male. 43-year-old male. 43-year-old male.
43 year. And this lymph nodal mass was where? In axilla?
Yes, it was an axillary mass. Yes.
So did he have nodes anywhere else in the body?
So this patient initially, this is the first thing that has come to us. This patient has actually been maybe worked up after that. It was not a known case of anything, and he was lost to follow up after that. So we don't have, what other PET scans or any scans that have been done to the patient. But when I spoke to the patient to, get a history about it, I asked whether the patient had any nodes in the opposite axilla, if the next basically thing that the patient had clinically identified, for which he told me that clinically he did not feel any swelling anywhere else.
I mean, when I have a case in which there is an unusual presentation of a well-defined disease entity, so before I give a definitive diagnosis, because you all must do this because more and more litigations are happening in India. So I would advise that this is possibly the best diagnosis of this specimen that has been submitted to us. But I would advise a complete radiological workup and a PET scan and all that before for confirmation. Because classical is that it is young individuals with a single node, especially in the cervical area. Because I thought of this as a T cell rich because there were so many nodes, and I'm sure all those nodes showed the same pattern.
Yes, that is
I thought that we are dealing with a T cell rich B cell lymphoma here. That is my first diagnosis. And then and I'm now more and more we realize that all kind of things have been done. You can have stage 4 NLPHL, you can have multiple organ involvement in NLPHL and then abdominal NLPHL, all kind of diseases are being reported, all kind of variants are being reported, but they are not time tested. Many things which are reported are for reporting. And unless our textbook write that, unless it comes in our WHO, I hesitate to diagnose. And I always write a comment that this is required for confirming.
Very nice, very nice. It's a very good point that dealing with anything unusual clinical setting and unusual histopath, clearly one should give in the comments section that these are the riders, because we do have to protect ourselves. We all work very hard on our cases. We work very hard on our cases, and that has to be reflected in the report too, in the comments section.
Absolutely. Very interesting discussions, ma'am. I think this was quite this is always a heated topic. NLPHL going in the THR, BCLs, and the overlaps and the gray zones in lymphomas, they don't cease to end. We have to make matters worse. We have now two bodies. One is the American body, the other is the European body, without naming them, and they both have fights among themselves now. One wants to call NLPHL as NLPBL, they want to call it a B-cell lymphoma. One says we are there, but not exactly there. We are almost there, but not there as yet. So I think, as ma'am has rightly said, and you have rightly said, that till the time it doesn't enter WHO, we must be cautious and we must always give our necessary riders. With that, I would quickly proceed to our last case. It has been extremely interesting all this while, and people have all been very engaged. So Dr. Anukya, over to you for the last case, which is actually a case of 38-year-old male patient with a pelvic mass, query prostatic origin, and biopsy which was done elsewhere was suggestive of GIST, and the patient was started on imatinib, and you got this case for your opinion. Please go ahead.
Yeah. Thank you, sir. Good afternoon, everyone. I'll just share my screen. I hope I'm audible and you all can see my screen.
Absolutely.
Okay. So as Sir has told that this is a 38-year-old male patient with a pelvic mass origin query prostate, and biopsy was done outside and called it as gastrointestinal stromal tumor. However, only it was called as histomorphology, suggestive of, but IHC was not done. But empirically, this patient was started on imatinib. The PET-CT was done here, and they also went back to the previous PET-CT, which was done after a month of imatinib treatment. So they had seen that there was increase in the size of the it was a large heterogeneously enhancing lobulated mass in the pelvis, which was measuring 16 centimeter in the greatest dimension with a SUV max of 13.2. And previously, before the treatment, it was 14 centimeters in greatest dimension. There was definitely increase in not responding to the imatinib treatment. And also, it was seen completely infiltrating and replacing the prostate. Also, it was seen displacing the urinary bladder, and it was infiltrating the muscles as well. So on gross finding, the surgeon told me that they could not remove the tumor en masse, and while they were operating, it was broken into bits and pieces. That's why we got it in piecemeal, which was measuring around 23 centimeters in greatest dimension. Focal grossly, I could see some myxoid areas. I could clearly see that they were infiltrating into the muscle bits, which was in keeping with the PET-CT findings. However, I could not identify any prostate gland separately. So on histology alone, sorry, I think there was coming to the microscopy. So this was a tumor. We had given multiple sections to see to study the tumor from different areas. As we can see that these are sheets and some vague nested or alveolar pattern of the spindle to some epithelioid, or you can also call it round cells with coarse chromatin and prominent nucleoli. I'll show you it in the higher power. And we can see that there are few thin strands of some collagenized or sclerosing stroma around these cells, around the individual cells, and also in between some this vague nested pattern. So coming to the higher power, we can see that there are some few prominent nucleoli and some sclerosing or collagenous stroma around it. So anyone would like to say anything on this? I mean, I know it's very difficult, but we went ahead with the IHC panel, of course, and with the usual spindle cell panel that we would go forward. So to begin with, these were the differential diagnosis on histomorphology alone that we had. One first thing, we wanted to rule out carcinoma, any poorly differentiated carcinoma, followed by the retroperitoneal or the pelvic masses, which are more common, leiomyosarcomas, MPNSTs, fibrosarcomas, sclerosing epithelioid sarcomas, extraintestinal GIST, like someone had called it GIST on histomorphology alone. So we wanted to rule out that as well. So a poorly differentiated synovial sarcoma, melanoma, and any undifferentiated malignant neoplasm. So to begin with, as I had told the differential diagnosis, we wanted to rule out any carcinoma first. So we started with a PAN-CK, which was dead negative. SMA, some focal non-specific staining was, weak non-specific staining was there. Then coming to the neurogenic origin tumors, to rule out that, we did S100 and SOXTIN. S100 and SOXTIN both were negative. CD34 highlights the internal control was positive, however, the tumor cells were negative. CD117, again, a non-specific staining, but we counted it as negative. So, yes, sir.
There are certain differentials that people have given, and
okay.
a lot of them have actually said sclerosing epithelioid fibrosarcomas and sclerosing RMS. And one has even asked whether BCOR was done. Just wanted you to know. Right?
Yeah, I'll come to that, sir. These are very good differential diagnosis, and definitely because of the sclerosing the stroma, it was very clear that, like, you come down to a specific few diagnoses around. I'm really happy that few people could actually come think about it. Yeah. So CD117 was negative, and DOG1 again, both were negative. Yes, so coming to again lineage specific markers, Desmin Cape diffuse cytoplasmic, all the tumor cells were highlighting Desmin. So since SMA was showing some non-specific and Desmin was diffuse, we did an HCAL Desmon, which came out to be negative, and hence we rule out leiomyosarcoma. So coming to the clinching IHC, which gave away the diagnosis, was diffusely nuclear staining for MyoD1, However, myogenin was diffusely negative. So that is something very important. Whenever we are thinking of RMS tumors, we should also always do a panel of markers starting with desmin, MyoD1, and myogenin. At least we do that just to rule out all the other different variants of RMS. Coming to Ki67, which was very high, around 70 to 80%. And since it had a little epithelioid like looking like also, so we did INI, which was weak, but it was retained. So CD99 we did, which was a little non-specific but diffuse staining. However, NKX 2.2 was negative and TLE1 was also negative. So anyone like those two diagnoses, someone said epithelioid sclerosing sarcoma, but I would point out that in epithelioid sclerosing sarcoma, I think INI will not be retained. So, but in our case, it was retained. Coming to the other,
Yeah,
BICOR was
everybody has
not.
now given the diagnosis.
Yeah, perfect.
We have
Yeah,
got
yes.
a lot of people who have commented sclerosing rhabdomyosarcoma, and some have actually asked for moleculars in this case.
Yes, definitely. We did that. Yes, that is very correct. It was a very interesting case, and I think most of them have got it. So yes, this is the IHC panel that we did, and like, however, like what Sunita ma'am said and Abha ma'am said, that we need to put the caveats, and alone IHC will not help us to give out the final diagnosis, although we were very sure. So we said that it is suggestive of spindle cell or sclerosing rhabdomyosarcoma. However, this is a little rare as compared to alveolar RMS. We suggested that they should rule out the alveolar RMS first by doing PAX3 FOXO1 and PAX7 FOXO1 gene rearrangement, followed by MyoD1 mutation analysis. So we went ahead with that. An NGS panel, a diffuse NGS panel was done, which included MyoD1 mutation panel, SNVs, and also fusion gene panel. In fusion gene panel, they ruled out PAX3 the FOXO1 gene fusion, which were negative, and they found that MyoD1 missense mutation varial allele fraction was seen in 99.7%. So this was also even the molecular test NGS panel was supporting our immunomorphological diagnosis. So just a little literature review. These are very rare as compared to the alveolar and embryonal RMS. 3 to 10% of they constitute 3 to 10% of the rhabdomyosarcomas, and 3 subvariants are there, and MyoD1 mutant, congenital, and intraosseous as well. So the head and neck is most common site, followed by the extremities, and in pediatric population, paratesticular region is more common, followed by head and neck and other regions. Rarely viscera like uterus or retroperitoneal or prostate is seen, which is in which is a little rare thing. And in our case also, like when we went back and spoke to the nuclear medicine people, they said that it is more likely to be prostate, because they had also compared the previous MRI and with the current MRI. So that's why they were saying most likely to be from the prostate, but they were also not very sure. So we took it as a pelvic mass only. And also there is a decreased male to female ratio in specifically in MyoD1 mutant genetic type. So again, it's a rare, it's more common in females is what the literature says. However, our patient was a young male patient. So this is the diagnostic molecular pathology. The WHO has laid down the essential criteria as cellular spindle cell fascicles or tumor cells in a variably sclerotic or collagenous background. That's a clinching on morphology, so it should be thought of. It should be the tumor cells should be positive for desmin, and myogenin focal or negative, they say, and MyoD1 should be diffuse positive. And in desirable criteria is MyoD1 mutations or other or various gene rearrangements that I have mentioned before. So important to the takeaway message is that it is very important to diagnose these cases, because if they are congenital or infantile spindle cell or sclerosing RMS, they have a favorable clinical outcourse. But if they are adults, they have an aggressive outcourse and which requires a multimodal therapy. And the 3-year and 4-year survival rates are very low, which is 36 to 18% respectively. So these are the very rare case studies where they say that spindle cell RMS of prostate. Until now, only 9 cases have been reported. These are my acknowledgements to Dr. Imran, who's the section head and senior consultant pathologist, a very enthusiastic and enthusiastic senior who always guides me in difficult diagnosis like this, and Dr. Ansa as well, my junior pathologist. Thank you so much.
Thank you, Dr. Anugya. I think it was a very, very interesting case. Just a few of my thoughts before I give Abha ma'am, to close this. One thing is that, it's a little sad to see that GIST was diagnosed with CD117 and DOG1 negativity and therapy was started. A trend that we all collectively together must change in our country. We must understand in cancer, we are talking about lacks of treatment, and a misdiagnosis is a mistreatment and it's usually fatal. So that is, the importance of diagnosis is extremely pertinent here. Another message that I would like to give everyone through this case is that please understand there would be cases where a myogenin or myod1 might not come despite it being a rhabdomyosarcoma. You should try and do both wherever it is available, because otherwise you can probably, land up in trouble. Then something that really strikes me in most of the conferences that I go to these days as a presenter usually, but it's very widely visible, is that how much of hematolymphoid neoplasms form our presentations. Even today, if you see, a lot of them were lymphomas, and slowly picking up is sarcomas, because there is so much of overlap and there is so much of moleculars which have come in sarcoma especially, that a lot of diagnosis now, just like CNS, Sunita ma'am would probably agree, how CNS is so much molecular these days, sarcomas is moving towards that. And we are, in a zone of defining quite a lot about lymphomas. With that, I would like to thank everybody from my end for being a part of this. People who have taken their time out, all the pathologists, Sunita ma'am also for her valuable inputs, and especially Abha ma'am, who made this happen, who thought of this idea and who was so enthusiastic about it. Ma'am, over to you for your closing comments.
Thank you, Kunal. I think all of us have enjoyed the session today. The cases were all very interesting. The presentation was good, and the icing on the cake was the discussion. And it was nice to see everyone giving their differentials and participating in the discussions and persisting with their queries and their doubts. So I would like to get feedback from all of you. You could direct message me, and let's continue with this. I feel we should continue with this. Whenever you have an interesting case, take the images, send it to Kunal for scanning. And as soon as we have a good number of cases, periodically, we would like to conduct these sessions.
We can make it organ specific and few cases.
Right. Depending upon the input. Depending upon the
I think a
inputs,
lot of people are asking about recording,
cases.
whether it will be available or not. I think it will be available for all to see.
Yeah, and any doubts that are there, the discussions can continue offline now.
Sure.
Right? And with
Thank
that, yes,
wherever the molecular and all has been done, please publish. Kunal is the editor of Surgical Oncology.
Yes, ma'am. Looking forward. Thank you. Please do.
Absolutely. If we, inculcate this culture that when we see an interesting case, let's discuss it, let's share it, and then ultimately it's going to get published and benefit the individual themselves. So thank you all. Thank you for attending. Thank you for the discussion. And thanks, Kunal, for putting it all together.
Thank you. Thank you, everyone. Thank you.
Thank you.